Hi, good morning, everyone. On behalf of Humana, thank you for joining our National Press Club event today. I want to start by thanking our panelists for joining us as well, and I'm going to introduce them in just a minute, and you're going to hear a lot from these game changers as we go throughout the day today. Thanks to those for you who are joining virtually. Like many others, we really wanted this to be an in-person event and live streamed as well, but unfortunately, circumstances didn't give us exactly what we wanted. Certainly our hearts go out to those who have suffered personally, and our thoughts and appreciation remain with those who are on the front lines of this pandemic and who are out providing care for us. Additionally, we're at a pivotal moment in our country's history. Our future will really depend on the actions and our commitments that we make today and position us for a better tomorrow. Caring for each other and respecting differences is who we are as a company at Humana, and we don't tolerate racism or discrimination of any kind. At the core of our values is really serving the communities in which we operate. I'm Cockerell, and I lead strategic relationships at Humana, and I'm very proud to be a part of the Humana Integrated Health System Sciences Institute at the University of Houston, which we founded earlier this year. I'm also part of the Bold Goal Office of Population Health team at Humana, where we're really working hard to improve the health of the communities we serve. And I was fortunate to start our Bold Goal work almost 6 years ago, and it's amazing to see the progress we've made in a relatively short period of time. So let me give a brief introduction of each of our panelists, and then I'm going to ask them to provide a little more context about who they are and their work with Humana. First is Dr. Steve Spann. Steve is a family doctor and the founding dean of the University of Houston College of Medicine and the Humana Endowed Chair in Medicine. He's at a really exciting time in his storied career. He's about to admit the first class of the College of Medicine in the next month. Next is Dr. Yolangel Hernandez Suarez. Yogi is a former Humana colleague and is now the Associate Provost for Clinical and Community Affairs and Associate Professor in the Herbert Wertheim College of Medicine at Florida International University. Yogi's an OBGYN by training and a fantastic partner of ours. Finally, Dr. Greg Moore. Greg is a doctor. He has his MD and is training in neuroradiology and also a PhD in engineering from MIT. Greg currently leads Microsoft's health efforts globally and is responsible for product strategy, product development, and research, including artificial intelligence and machine learning technology. So welcome to all of you. Thanks so much for giving your time. You're all very busy folks, and I really appreciate you being here today. I know that our virtual listeners are really going to enjoy hearing from you today. The topic of our panel today is focused on health education and technology, and that's why you're the perfect three to have in this conversation today. There's a tremendous intersection of these domains as both are really evolving very rapidly, and I know you can all speak to that very eloquently. Before we dive into questions, maybe each of you just give just another brief minute or two about your background. Steve, you want to give our audience a little more context about who you are?
Yes, thank you, Trey. Good morning, everyone. It's great to be here today and joining in this discussion. So as Trey mentioned, I'm a family physician by training. I've had a very broad-ranging career experience, beginning with 4 years as a country family doctor in rural Arkansas and North Carolina to almost 40 years now as a full-time medical educator in actually 7 different medical schools, literally around the world. Department chair at 2 medical schools and now dean at 2 medical schools. Also had the wonderful experience of working for 2.5 years for Johns Hopkins Medicine International in the United Arab Emirates prior to coming to the University of Houston 5 years ago to start a brand new medical school, which has been an exciting endeavor. I have been an early adopter and embracer of technology all of my career. I installed the first electronic health record at the University of Texas Medical Branch in 1994, at Baylor College of Medicine in 1999, and then rolled out the first college-wide version of Epic at Baylor in 2009. So I am a firm believer that technology is a great tool that allows us to take better care of patients and to better educate our students. I look forward to our discussion. Thank you.
Thanks, Steve. Yogi, you want to go next?
Yes, good morning, everyone. Yogi Hernandez Suarez. I sit here today as the Vice Provost for Population Health and Wellbeing at FIU, Florida International University. FIU sits in Miami. We are part of the state university system, a R1 public research university. We are a majority serving university. We are a large footprint of the Miami-Dade community and an anchor institution for South Florida. We are a large university. There are 58,000 students and 13,000 faculty, staff, and administrators. We are known globally. International is our middle name. We are known for global stewardship, and we are also known for social entrepreneurship. For those of you familiar, we are an Ashoka Changemaker University, and we are here for the impact. We're a relatively young university as universities go, and so we are scrappy and nimble and hungry to make our difference. We are of the community and for the community, and so we have a deep interest in population health as it pertains not just to our internal FIU community, but to the communities that we serve. And so we are delighted to have a partner in Humana who is thinking about the mid and long-term health of communities. We are both entrenched and committed to the health of Florida. And I look forward to hearing from everyone today. We are in a state that is still undergoing rising numbers of COVID-19 patients, and we've seen tremendous impact to our education and to our community, which I look forward to hearing from our other panel members today of how they are managing through this and lessons learned. Surely technology has played a role of this, and we see only more value to not just technology, but deep understandings of data as we move forward. So thanks for having us today.
Fantastic. Thank you so much, Yogi. And Greg.
Thank you, Trey, and just delighted to be here with you, Trey, Steve, and Yogi. It's going to be such a super panel today. Myself, Trey, as you had said, I'm an engineer and a physician. My career has spanned education, technology, and healthcare, and spent much of my career, a little bit about me, spent much of my career in academic and integrated healthcare systems, educating graduate students, medical students, residents, and fellows, much like my colleagues here on the panel have today. So delighted to participate here. Couldn't be more delighted about our partnership with Humana, Microsoft bringing technology to empower every person and every organization on the planet to achieve more. And that couldn't be more important in the areas of education and healthcare, and bringing that technology and partnership together with to really benefit Humana's members going forward. I know we're going to get deep into technology and how it can be used in healthcare and education today, and just really look forward to that discussion going forward. So thank you, Trey.
You bet. Thank you. And really excited about our partnership with all three of your organizations. We are doing some fantastic work already together, and a lot more on the horizon ahead of us. So really appreciate your partnership. So let me just start and ask, how your organization has changed your approach to education, and what do you see as the biggest challenge moving forward? And maybe Yogi, if you want to just get us started, that'd be great.
Sure. And I imagine, like many of us listening in today, we got a call that said, tomorrow you won't be teaching on campus and learning or working on campus anymore. And that call came in March, and that had to essentially galvanize and change so many things for a very large and complicated organization that is a university. We have multiple campuses, we have regional campuses, we have international campuses. We are a minority majority serving university, and the majority of our students live at home or in community. And so we have the added complexity of not being able to predict essentially what people were going home to be able to continue their learning as far as technology and Wi-Fi and room to sit down and be able to do their thing. And I imagine many people on this call face the very same circumstances for our safety, right? If this was an appropriate and quick response that we got from a directive from the state. I can tell you, I think part of the reason we have been so successful in this transition has to do with the resilience and the infrastructure, and I would say the DNA of the university, and in being a change maker, right? So we as a university all trained together and went through a process to understand what it means to be nimble and have the opportunity to respond to an emergency. Now, I won't say we have the advantage, but we have the practice in Miami of doing this a couple of times a year in response to a hurricane, right? So we have some muscle memory on this, but nobody has done what we have done as a state or a nation, where we've been teaching at home for 3 months. I think the hardest hit have been our clinical services. Think about our doctors, our nursing students, our social workers. These are people who must train in community. We do not own our own hospital system, and we are proudly a community-based academic health center. And it's only been, frankly, because of the good partnerships we have with our clinical affiliates that we've been able to navigate through these 3 months and plan for the reentry of our clinical learners into community. Clearly, this is a generation of clinical learners who will be impacted by this. I grew up, and I imagine, Greg, I can't tell your age on a Zoom, but I grew up in the time where AIDS was being discovered and defined and managed. And I can tell you every week it was a different week of what this had to do with our career and what we were going to be expected to do, again, as an OBGYN. The AIDS was seminal to how I practiced and grew up in medicine. I imagine this generation will be imprinted by coronavirus. And to that end, I think, if nothing else, we should never let a good crisis go to waste. And I think there have been some really emerging great pedagogic practices that we should hang on to. And I can tell you, as an organization, our president is not asking us to go back to what we were. He is asking us to think about what we could be following this disruption, with the understanding that we are going to ebb and flow out of quarantine over the next couple of years, or miraculously less if a vaccine and herd immunity comes to us sooner. So technology, a big part of that. But again, revealing, and I'm sure we'll get to that, some of the social determinants of health that we are going to talk about: poverty, access to Wi-Fi, access to privacy, and I'll cede some time for the other panelists to respond.
Greg or Steve, any thoughts on that?
Well, we've been in the midst of planning a new medical school. Our first class doesn't start until July 20th. Now, it is a challenge to build a new medical school, but it is another order of magnitude challenge to build a new medical school during a COVID pandemic. We had to do essentially all of our student applicant interviews online. Having said that, it has, I think, allowed us the time to prepare for different contingencies in terms of instruction. Now, as a new medical school, our preference would be to do as much in-person instruction as possible as we get to know our students, just sort of develop our routines, and test our new curriculum. However, we realize that that may not be possible, depending on the progression of the pandemic over the next few weeks. So our desire is to do a lot of in-person teaching with some virtual teaching, hybrid, what some people call high flex, where some students are present, some view the teaching over video streaming, and then some virtual. Small groups may be virtual. Some of it will necessarily have to be in person. It's hard to teach gross anatomy totally virtually. We have a gross anatomy lab. I want to put that to good use. And then there are the whole issues of clinical skills teaching. So we've done a lot of thinking about that and a lot of contingency planning. We think that we have to be flexible and adaptable, as will, of course, our students. Let me just say that our colleagues at FIU have been real role models for us. When we started thinking about building this new medical school, we visited 4 exemplar schools of medicine, and FIU was one of those. And we have actually borrowed some from their curriculum. I'll talk more about that later. But there are a lot of similarities between our 2 universities, and I suspect that we are dealing with very similar issues. The good news is it is a new normal. I think that there will be good outcomes from some of the challenges we're facing now in terms of helping us to do better teaching virtually and really maximize the potential of all modes of teaching. So we're open-minded, we're flexible, and we're anxious to get started. And I'm confident that it's going to be a fun ride.
Steve, that kind of prompts for me both your and Yogi's thoughts. And Greg, I'd be interested to hear from you that the utilization of technology really in the form of telehealth and telemedicine has become almost as prevalent as the smartphone itself. And I know yesterday on a panel that Caroline Coates moderated, we heard from Ochsner that they're actually conducting up to 3,000 telehealth visits a day now, which is up dramatically from where they were just a few short months ago, certainly before the pandemic. I'm curious, what do you see as the future of telehealth, not only as a learning tool for students, but also as a treatment modality for patients, and how technology can influence that going forward?
Well, I've had a long-standing interest in telehealth, and we've had a number of limitations, particularly in the primary care arena, just in terms of getting reimbursed for doing that. So I think one of the positive residuals, if you will, side effects from the COVID-19 pandemic has been really that telemedicine, telehealth has become much more mainstream in the practice of medicine and healthcare, including now the fact that it is being reimbursed. And so we hope that this will be the new normal. I think it's a great tool for taking care of patients. I mean, I've been doing some mode of telehealth most of my career. Before new technology and the internet, it was by telephone, right? And
Right.
then it was having patients send pictures of rashes on the weekend when they were suffering, and I was on call. And now full two-way video conferencing, which is just marvelous. I think it's a wonderful tool for continuity, for taking care of folks who have difficulty getting to see us. It's a time saver. I think patients love it. I think doctors love it. I hope we never go to a totally virtual practice. I think there is importance in being able to connect physically in person with our patients periodically. But wow, what a great tool. I think it's a great teaching tool. I think it is a tool to train our students in the current environment where we have some limitation to in-person contact. But the American Association of Medical Colleges is actually developing a curriculum, a core curriculum and competencies for telehealth, which I anticipate that all medical students will eventually participate in. So I think it's a great tool, a great gift, and I'm excited about the opportunity to use that more as we move forward.
Yeah, I couldn't agree more, Steve. And Trey, we saw the world go virtual practically overnight, and that was no different across industries, but especially in healthcare. We went from thousands of virtual visits to actually tens of millions of virtual visits, on for instance our platform Teams, and we feel, as Steve suggested, and Yogi as well, that this change will be persistent. So the world is changing. We will go to a new normal, and patients and clinicians are having very positive experiences here going forward. I think what is exciting to me, so that this has so exciting to me, is it has really changed the pace of innovation. As an engineer that's been working in healthcare for some time, and as a scientist, it typically takes somewhere between 12 to 17 years for when we publish a paper until we actually see that technology on the floor of the hospital when we're doing rounds. What we've experienced with COVID-19 is that it's accelerated in some cases to weeks, where we can have a technology development to actually see it in our practice and the practice of our colleagues every day. And some of the, as Steve suggested, and Yogi as well, some of the important policy barriers have come down as well to allow reimbursement, to allow interstate telemedicine, to really provide access for patients and connect them for the providers they so much need for this care. So it's a great, although this is COVID-19 has created tremendous challenges for us all, and our patients and our students and our learners, it's also created this tremendous pace and speed of positive transformation in healthcare, and we think that'll persist. Technology is at the core of that, and I think as we think about access to care and social determinants, technology can have some very positive impact here in creating access. We have to pay careful attention that access here, even with technology, is available and equitable as we go forward, and something that we're very focused on. I know that Yogi and Steve and Trey are, you as well.
Yeah, and Greg, you mentioned Teams. We certainly appreciate what Microsoft is doing as an advocate and an enabler for technology, and that's fantastic. And maybe just kind of, you mentioned all the results of the pandemic and what's going on with COVID-19. And Yogi, I'm just curious if you have some thoughts around how private and public sectors can work better together to address COVID-19.
Well, I would say we must work together, right? So that this is not going to be solved by any sector, right? So this isn't solved, just like any complex problem, or to use a social or economics term, a wicked problem, right? So a wicked problem is a problem that changes as you address it. And that is what we're seeing with COVID, right? So what we thought worked 2 weeks ago now may be irrelevant. And so it requires a set of problem solving abilities that are not linear, right? So you need a lot of cognitive diversity at the table, and you need a real collaboration across sectors to do things. And we've seen some of the breakthroughs in coronavirus come from that, meaning, just to reiterate, it is the policy change from compensation and statute that allowed telehealth to free up, that then allowed all of the innovation and access that you're hearing about, right? So critical in our community was access to information and telehealth visits for relatively well people who would have otherwise crowded emergency rooms and maybe even put each other in harm's way. So from a population health perspective, being able to bucket where people get service is critical. But that's not going to come if all of the sectors, private, public, government, are not at the table because this is bigger than all of us. And coronavirus in our community, and I'm sure in many others, has shone a light on every fragile bit of the healthcare system. So if we ever needed that to happen for us, and those of us who've worked in the safety net, we sort of live this and know it, but it hasn't been widely understood, even by legislators. This is it. This has shown it all, and it has shown it in a way that has been intersectional and across populations. And so, again, what is the opportunity then to grab that momentum and that political agenda and say, look, and what can come out of it? Who would have thought that bandwidth and access to Wi-Fi would be a health equity issue? And it is. It is a health equity issue, just as it has become an educational issue. There's so much in common with what we're seeing in universities from social determinants as what we're seeing in healthcare. And it's just showing the underbelly of what we can do. Now, I'm a business girl too. And I also see lots of opportunity for people to come forward and innovate, to problem solve. Now, this isn't easy problem solving. This is complex problem solving. And even in the innovation world, you're going to have to come to the table with extraordinary, I would say, almost diplomacy skills to be able to bridge sectors. And that's why I think what Humana is doing is exciting, acting as a convener in a way, as a catalyst to bring the sectors that you see here represented to think about some of the hard problems that we still have to face. But I'm with you, Greg, that I think that, and honestly, if anybody smart out there is listening, if you could solve the electronic medical record problem, that would be really great. Think about a telehealth visit that happens, and using artificial intelligence and natural language documents that moment, captures that moment, so that the clinician does not have to go back and type everything. I mean, I know that there are a lot of clinical people on this call, and they, everyone's rolling their eyes about the work that we do that is hard for us to value. So I'm hoping that the big hairy problems that we went into this with get addressed and looked at, so that again, we don't go back to where we were. And if we're not going back to where we were, going back to Dean Spann, we have to train people differently. We may even have to pick different kinds of people. Who gets to be a doctor? Who gets to be a nurse in the future? What do they bring to the table? They're going to have to bring 2 and 3 scoops of resilience and tolerance of ambiguity. And we haven't really been always looking for those folks.
So you brought up a couple of really interesting things there, Yogi, and I'm curious, Steve, to get your perspective, focusing on the safety net, social determinants. I know that you really spent some time getting students who are going to be really prepared in that area, and not just prepared to deal with social determinants, but educating that next generation to be prepared to address a pandemic or deal with this in ways that we haven't been prepared for in the past.
That's exactly right. And we have to remember that social determinants of health are a major contributor to preventable morbidity and mortality in this country. Some experts believe that they account for as much as 80% of that preventable morbidity and mortality. So it's absolutely imperative that our future physicians and future healthcare professionals learn about this. We have a number of curricular elements that will make this front and center of our curriculum. In fact, the first week of class is actually focused on teaching our students about social determinants of health and health disparities. Throughout the curriculum, our students will spend a half a day a week, every week for 4 years of medical school in a primary care setting, many of those students in a federally qualified health center. So they will be learning real time from the very beginning about social determinants of health and how upstream care can prevent downstream illness and disease. We have, as part of that, of course, a segment that we adapted from our colleagues at FIU. We call it household-centered care. And this is an experience where our students will be part of an interprofessional student team that includes not only medical student, but a nursing student and a social work student, and at different times, students from other disciplines that are relevant to the care of families with complex medical and social problems that live in underserved communities. Each team will be assigned a family and will follow that family longitudinally over the 4 years of medical school, visiting them on the average about once a month. From that real world, community based clinical experience, they will learn all about social determinants of health and health disparities, if you will. We also have uh, the goal of finding ways to engage and partner with some of the geographic communities near to us that have major health disparities to work together. Not us coming in and saying, we're going to fix your problems, but hey, what do you see as your health problems and how can we work together to improve health in your community? And a lot of that, again, is related to social determinants of health and to finding ways to provide better care upstream to prevent downstream illness and disease. So a major curricular focus, both at a classroom didactic level and at a community experiential level.
Yeah, that's well said, and it's a great example of why we love this partnership with the University of Houston, and it's exactly what our bold goal is all about. And being able to demonstrate progress in helping address some of the social determinants of health that are most prevalent in society is something we've been focused on for some time. And, again, proud of this partnership and know that we'll have an impact on education and on those outcomes in the communities near and dear to your heart for sure. And same thing in South Florida. Yogi mentioned the use of technology and Wi-Fi in particular. And certainly we're seeing that's another social determinant that really doesn't get quite as much of attention as things like food insecurity and stable housing have in the past. But I'm really curious, Greg, if you have any thoughts on how we might best collaborate to provide those tools to communities that are going to enable a new type of healthcare delivery through the better use of technologies like, better Wi-Fi, AI, machine learning, and things like that.
Yeah, absolutely. And there have been great points made by Steve and Yogi here on the use of technology, Trey. So it does start with bandwidth and Wi-Fi there, and that's much of America is rural as well. So there's also barriers for long drive times to care, inhibiting access. And so this is why telemedicine or video conferencing, once we have that core infrastructure in place, which is both a technology and a policy decision. So it's really working technology companies together with government and telecommunications firms to really make sure that we have that equitable access. And Microsoft's hard at work at that, and many others are as well. The technology platforms in Teams, we have spent hundreds of years of engineering effort and as a foundation to be sure that we have the highest levels of security and compliance. And thankfully, we pre-invested years ago now to make this all HIPAA compliant, so we can actually have medical conversations. So this is amazing, and ability to actually scale what it really is a precious and scarce resource in healthcare professionals going forward. And this allows us to actually extend the professional and specialty care. But I think, as was touched on a moment ago by Steve, up-leveling even our primary care providers with the use of telemedicine. A brief consult, as Yogi and Steve know, to a primary care physician can really up-level them and provide them to have care just with a brief interaction to really provide that access at that last mile that would sometimes be delayed by a month or maybe never happen because of a commute or a long drive or an added expense. So really important, even the provider to communication to up-level going forward. And of course, we and just reflecting, and Yogi reminding me of this, where have we come even over my medical career? We went from medical records that were written, 98% written, to now we find ourselves 98% digitized across some of the work. Steve was directly involved in implementing some electronic medical records, as I know most of us have, across systems. But this has brought us tremendous opportunity now to use that for individual healthcare systems, healthcare plans, to use that data for insights. I know Humana is very involved in this, as well as most healthcare systems as well, to use machine learning, AI-enabled insights to flag our most sick patients in the hospital, to save lives. Looking at things like sepsis now, algorithms already embedded across numerous systems to do this. But also in the flow of in the workflow of how we care for patients and even admit them. And coming back to COVID-19, we've seen the literal, in addition to virtual care, we've seen a little explosion of AI-enabled healthcare bots across the system. Ourselves, we've implemented now in over 2,000 healthcare systems in just a few weeks in 23 countries, including the CDC, tens of millions of encounters, all using healthcare bots simply to be able to triage symptoms and then do a warm handoff when required to a provider. And that's just another way we've used technology to scale to give providers actually time to care and to really unload call centers, even to be able to direct patients going forward. So just a few examples there, I think, of the opportunities ahead and what's been driven here.
It's fantastic. Thank you, Greg. And the pace of change is truly incredible. A few years ago, we found some ledgers that were my grandfather's, and he was a physician, a family doc, rural doc around the turn of the 20th century, so around 1900. And the ledgers talked about the barter system. You got chickens or eggs in exchange for delivering babies or setting a broken bone. Certainly no EMR, just a dramatic change in a short period of time. I want to take a little bit of time and take some questions from our virtual audience, and we've got one that's come through that I think is pretty interesting. Do you have any advice for students just now entering the medical field and new doctors? And how can they best prepare in this new environment with new technologies and new education and the rapid transformation of healthcare?
Well, I think they're well positioned
go ahead,
because they're digital natives, so to speak. They've grown up using technology and are much more facile with it than we are, perhaps. And I think that they can look forward to continuing to harness technology to improve the way we take care of patients. I would offer, however, one hopefully important thought, and that is that as we gain experience as physicians, we come to recognize that we heal through relationships, that the doctor-patient relationship is absolutely core and critical to healing. And there's a wealth of evidence to support that. And so the point I would like to make to them is that technology will never replace that. It will simply enhance it. And so, that's a good thing, right? We don't have to give that up. We don't have to give up the in-person connection, the occasional ability to reach out and touch our patient physically in an appropriate way to provide support and compassionate care. But the technology will enhance that because it will be easier to catch up with them, to touch base with them when they're at home and can't come to see us and so forth. So great things to look forward to, but the art of medicine, the caring, the compassion, the healing through relationships will still persist.
Yogi, did you want to add something to that?
I was going to add, and just to build on what the dean has stated, I got early advice in my career that has stuck with me, and that was, you'll always have two jobs, your job and your career. And what do I mean by that? No one will manage your career or think about the trajectory of what you are going to contribute except you. That is up to you. And so one of the things I encourage, young physicians as they think about what it all means is, yes, you're going to have to excel at the job that is in front of you, whatever that is at the moment. But I encourage all of you to think about what is coming and how can I engage with that over the course of my career to contribute in bigger ways. So in my lifetime, it was important, I think, for me as someone caring for women to contribute by getting a seat at the table where decisions were being made for women and women's health. And so I overlaid on my clinical learning policy, administration, business principles, et cetera. And I think Greg is probably a prototype of the physician of the near future. How, we all have to, everyone on this call knows how the kidney works, right? You don't get out of learning and understanding medicine. Some of us probably understand the kidney better than others. But having said that, what do you overlay on that as work on your career, and how does that help you contribute to what cannot be static? We have to do our job, but we also have to contribute to the progress of medicine, which has now become exponential since the middle of the last century because of discovery and scholarship and innovation. And so there's going to be things that you will be able to do in medicine that that we haven't even thought about yet, those of us on this panel. Who of you will be that icebreaker? Who of you will say, I see the next thing as well as the current thing? And every sector benefits from that. The other last bit I'll say is the more intersectional work you do, the better you serve as a Rosetta Stone. And I imagine, Greg, you and I serve as a Rosetta Stone frequently in boardrooms, right? So you translate engineering to clinicians and clinicians to engineers, and I can translate business to educators and education to business. These are going to be increasingly needed in medicine. And so for those of you who are called to that, I can think of no better time to think that through and find mentors who can help you get to that kind of a career trajectory.
Yeah. Along those lines, really becoming a strong population health manager, when you're a physician, could potentially be the equivalent of getting a master's degree in IT or a doctorate in engineering. Do physicians of the future really need to be experts in AI and data analytics, Greg?
So here's how I'd answer that question. One, just to go back to the prior conversation, I would say that medicine and healing is at its core a human experience, and technology and science are tools that are enablers to actually extend our access to do things that we couldn't do before as individuals, and really to extend that. And I guess I'd use my own career as what do physicians of the future need? Physicians don't need to become a data scientist or machine learning engineer or AI. I would say physicians in the future do need to educate themselves on informatics. And I know most medical schools now are actually incorporating informatics platforms. It wasn't a part of my education in medical school, and it hasn't been for most. But
I don't think that word existed.
But we are asking now, as we go from medical school to actually your first day on the floor as an intern, you're confronted with really these powerful informatics tools and different silos of information that you actually have to navigate to provide care for your patients. And so I think that's critical to be facile with information. And Steve, as you said, digital natives are good at that, and it comes second nature. But some formal education on where those silos of information are, the questions you can ask, making sure that we don't have iatrogenic complications. So the electronic iatrogenic complications there, being aware of those and establishing best practices and how to use information for not only the best care for an individual patient, but populations of patients, and to gain insights on those trends across not only a hospital but a region, even nation states. So these are now, this with information becoming available, an individual physician at a terminal can really gain some insights even on what's the best antibiotic in my region in terms of sensitivity with a few keystrokes.
Certainly love the notion of it, being complementary and really helping physicians. You don't have to be an expert, but you got to learn some new modalities and some things that will really boost your ability to be a very strong physician in the future. So appreciate all those answers. We're getting close on time. I do want to ask one last quick question. Steve and Yogi, I've heard both of you refer to patient care as a team sport, and I love that. Can you talk more about interprofessional education efforts at your institutions and how students are learning in teams and learning to work in teams to deliver more holistic, integrated care to their patients?
Sure, that's one of the major foci of our Humana Institute, and we are really working hard to find multiple ways, really, to train healthcare professional students together, because it is a team sport. I would point to the household-centered care experience that I described earlier as one great example of that. In addition to those clinical experiences, we will be doing some didactics together, having students from various health professions in the same classroom and learning together. And then we will also be, of course, doing a simulation that involve healthcare professionals from multiple disciplines. So absolutely key to healthcare education of the future. And we're doing our best to find innovative ways to do that.
And obviously, when people are early in their career and are learning, you get a chance to imprint on them, hopefully before more siloed habits are learned, right? So shared learning is very powerful when people come in sort of, blank slates, and they learn together, and they across disciplines, nurses, physicians, lawyers. I think that in our institution, through the neighborhood health program that the dean has described, has yielded really different collaborative abilities in our community. Doctors and lawyers learn to talk together. I mean, and that is very powerful. I will add that I think we need to broaden the usual players, and frankly, when we look beyond illness and we start to look at upstream work, which is why my position is at the level of the enterprise, right? So illness and response to illness, and the sicker people get, the more technically involved disciplines must be. But as you look at upstream work, we really have to think about the entire university, because I think that, for all we know, a lot of the upstream work will happen in the colleges of business and policy and other parts of the university. So part of our challenge is thinking about the university as an ecosystem for health promotion and health literacy. How in general can we just say, look, if you've got higher ed, you come out with a certain level of self-advocacy and understanding of healthcare systems. We certainly see that in Europe and Canada and other countries. America's sort of late to the party on that, and FIU is very interested in being a trailblazer for that, part of which is self-serving, in the sense that our students tend to stay in community and be the doctors, lawyers, teachers, civil servants, and the more they can come out equipped with a sense of their own understanding of health, holistic health, and what it means in community, and how they can advocate for it and be good stewards of health resources, that lifts all boats. And so I think the more upstream you go and the more upstream work you want to do, the more levers you want to have. And we appreciate Humana taking that broad approach with us and looking across our campuses, perhaps at non-traditional players, to help us think through these issues.
Yeah, fantastic. Good news is time flew for the last 45 minutes, but we're actually just about out of time. So I wanted to just maybe give each of you a last minute or so just to kind of reflect on the conversation today and provide any closing thoughts you have. And Yogi, maybe I'll just start with you.
Sure. So I've learned a lot, as I always do when we're asked to be part of these things. I always feel like I get a lot out of just hearing from the other panelists. I would say that although we today have spoken, I think, about the long view, I will state for the record that we are battling day to day here to figure out tactical questions. How do we reopen part of the campus? Do we play football? How do we teach organic chemistry? And so part of leadership's role in all of this is to be able to go up and down in that lens of how do we, manage the day-to-day operations? How do we go high to understand and see the mid to long view? And again, I feel fortunate to be at an organization that is open-hearted in its nature and is inviting of other sectors, other institutions to come to the table to help. I believe great scholarship and great learning will happen during these times. But again, as a leader in the organization, as I'm sure others on this call, we have to balance every day by the reality that we are still managing a life-threatening illness in our communities. As a minority majority serving university, we understand that communities of color are at particular risk. Many of our students and faculty and employees are in multi-generational homes. And so even though some of these conversations may have seemed lofty and forward-looking, we understand that our primary responsibility is to keep everybody safe and get them through this, but then position us to survive in the mid and long term and thrive. So again, thanks for the opportunity, and love our partnership with Humana and how it brings us great new partners such as Microsoft and the University of Houston, which I know is a current sister and will remain a growing ally with us as we change the nature of health outcomes in Texas and Florida.
Fantastic, Yogi. Thank you. Greg, any last comments?
Sure. Thank you, Trey. And I just want to thank my fellow panelists. I also learned so much, and it's an opportunity to participate in really important conversations such as this with you all. These have been incredibly challenging times for us all, sad times. And really, it's these times that shape us all as institutions and human beings, and really remind us that we are all part of one human family. And so, as I reflect on where we've been and where we're going, I'm an optimist of seeing us come together in ways, and we need to further that. And lots of work to do, but I've seen us come together for change in it's such a rapid pace, and to have, and more important, not only to drive innovation, but to drive that impact. And we're doing that together as public-private sector across our human family. And so I'm a believer that those bonds that we've formed and will continue to form will grow. I'm a believer in science in terms of being an optimist of getting us to a better place and providing technology to medicine, to really with you all here, and could be more thrilled to do some of this with Humana and our colleagues in the public and education sector, for this better outcome. So I'm going to keep being an optimist, because I think we have reason for optimism based on what I've seen over this last few months.
Well said, Greg. Thank you. And Steve.
So as has been said, I think that the current pandemic has shone again a light on some of the challenges in our healthcare system, and of the importance of continuing to try to achieve the triple aim of improving the health of our population and improving patient experience while controlling cost. It's also reminded us of the fundamental role that social determinants of health play in that value of care equation, and of the importance really of intervening upstream to prevent downstream illness and disease and costs. I'm reminded of the recent paper published by Dr. Don Berwick in JAMA Online just last week. And he said that these are not just social determinants of health issues, they are moral determinants of health. And now is the time for us as healthcare professionals and healthcare organizations to step up to the plate and demand societal reform.
Well, yeah, it's a fantastic article. And speaking of the moral determinants of health, I mean, we all do have that obligation. And I certainly appreciate the three of you for spending some time with us today. Really appreciate our partnership with you. And I'm so proud of what we are doing together and what our company is doing from our bold goal to improve the health of the communities we serve by 20% and more. And really focusing on those social determinants and the underserved population has been the hallmark of what we do. So thank you all so much. And thank you all for tuning in and listening. I hope you found this enjoyable and look forward to our next conversations together, folks. Take care.
Thank you.
Thank you, Trey.